obviously you're involved with HSCT on the NHS, but we know that you're involved with it privately as well. So in that instance, how much does it cost, and how long are the current waiting lists, and how long will somebody be away from home?
So the current package price that we've agreed for the private patients is around about £80,000. And what that includes is all the pre-transplant kind of workup, the actual transplant procedure itself, the inpatient stay, and then follow-up visits up to 3 months post-transplant. So we include all of that in the package. The patients can anticipate being in hospital for the best part of a month when they're actually having the HSCT procedure. But I like to keep them close by for the 3-month period, because most of the complications that are going to happen will happen in that period. So we do try and make arrangements for patients to be accessible to us for that 3-month period. In terms of waiting lists, we don't really have a significant waiting list. So if a patient was approved today, for example, for HSCT, we would probably be looking to perform that procedure within the next 6 to 8 weeks.
Okay, gosh, that's fast. Okay, which type of MS is HSCT most successful for, and what are the success rates that you've seen? And another question that sort of links in with this one that we get asked a lot is will my disability improve from treatment?
So HSCT is primarily directed at resetting the immune system. And so it works best in those patients where the immune damage is still a major component of their illness. So we know that that's normally people with relapsed remitting MS, or people with early stage disease, so not so many years since they've been diagnosed, within the first 10 years ideally, with relatively low disability score. So those are the patients who will benefit most, and will also notice improvement in some of their disability. But we also know that for patients with slightly more advanced disease, or where they've become slightly more progressive, then we can successfully halt the progression of further damage and functional disability in those patients. Now, the recovery is more difficult to predict in the more progressive phases. So will they get better? What we notice is some things do improve. So we notice people's energy levels get better very quickly. We know some things like vision, speech, bowels, bladder, they tend to improve. Mobility tends to be a bit slower if it's going to improve at all. And so we often say to patients, what we're hoping to do is to stop any further progression. And if we get an improvement, it's a bonus. Yes, yes. And our data, which we're currently about to submit for publication, suggests that about 70 to 80% of patients we do achieve that.
I look forward to reading that. That's great. What is the mortality rate at, well, in the UK over the last 5 years?
So the mortality rate overall, so if I look at both my NHS and private patients, mortality rate is less than 1%. In the private sector, we haven't had any mortality, but certainly in the NHS, there have been 3 deaths that have been reported in the last 5 years on this procedure.
And how many patients have you treated overall in the last 5 years?
So I've treated over 100 patients myself in that period of time.
Okay, and what protocol do you follow, and what is the process day by day for somebody that comes in for treatment?
So we follow what we call an intermediate intensity protocol. So this is the one that's most widely used probably now in Europe and also in North America. It's a combination of 2 drugs. One is cyclophosphamide and the other is ATG, which is an antibody therapy. It's probably somewhere in between the intensity that you may see in the full myeloablative transplant programs, but it's more intensive than some of the other protocols that are being used. Sorry, Alison, I forgot the last
And
question.
so what is the process day by day if somebody comes in? What happens?
So it's a two-stage procedure. First stage is to collect stem cells, and what we tend to do is we give some chemotherapy as an outpatient over 1 day. We then start some injections under the skin 24 hours later, and then roughly about 10 days later, we know there are enough circulating stem cells in the blood for us to collect. We bring them back up and collect them again as an outpatient on a machine called an apheresis machine, which allows us to collect the stem cells we need. After that, we then give them a week or two just to get over that, and then we get them in for the HSCT procedure itself. And that's when the first 6 days are where we deliver this intensive chemotherapy and antibody therapy to get rid of the immune system. We then take those stem cells we'd previously stored and reinfuse them like a blood transfusion, and then we wait, and we have to wait for the immune system to grow up strong enough for it to be safe for the patient to be discharged, and we have to wait for enough of the blood to have recovered so the patient is no longer dependent on transfusions and the risk of infection is reduced. So that's normally takes about 20 days after the cells are reinfused, so that's why they're in for the best part of a month.
Great.
Thereafter, we will do outpatient follow-up where we're checking their blood, monitoring them closely. One of the things with our protocol has been there's been an increased incidence of EBV reactivation. So it's very important that we monitor patients for EBV, which is why they need to have those blood tests done. So even if they're feeling well, we can sometimes detect it in the blood, and we need to treat when it gets to a certain level before patients become unwell.
Yeah. So you've mentioned the EBV and possible infections. Are there any other complications that are possible, and are there specialists in other areas that are available at the hospital to treat anything that's sort of non-HSCT related? And in terms of private treatment, would that come at an additional cost? Because obviously it wouldn't with the NHS. So it's quite a lot there I asked you, wasn't there? So complications, specialists to deal with other issues, and additional costs.
Yeah, so HSCT is a complex procedure with lots of risks attached to it, and although the mortality rate is low, that doesn't mean that patients don't become unwell during the procedure. And it's really, really important that you have a well-trained team around you to look after these patients. Mm-hmm. And so as part of our JC accreditation, we have to demonstrate that we have physicians from different specialties who are competent to give advice on transplant patients. And so we have a whole list of different specialties who are available to come and view our patients if they need their input. We also have on site our own intensive care unit, where if patients need to go down to intensive care, they will go down. None of this is an additional cost. This is all in the package.
Great.
So we recognize that most patients will never need it, but if they do need it, it's there in the package and they don't have to worry about it at the time.
That's great. Also, this is a question that we've asked you before and that you've answered for us, but it would be great to sort of have it as part of this interview. People are often told that, you know, you will lose fertility if you have HSCT. What is the truth of the matter there? Should people freeze their sperm, eggs, embryos prior to having HSCT? What would your advice be on that?
The fertility preservation is important, definitely for women over the age of 30. It is a high risk with our protocol that they will potentially lose their fertility. And so we definitely encourage anybody over the age of 30 to have fertility preservation if they haven't completed their families up to now. Under the age of 30, we still recommend you have fertility preservation because although the risk is that fertility may be impaired, we always take a safe view, which is better to collect because fertility may return, but we don't know for sure. And so our recommendation generally is of fertility preservation for all women of childbearing potential. Now, the issue is really around young girls who may not be in a stable relationship and may not have a partner. And so in that situation, you can't do embryo cryopreservation because there's no partner to fertilize the embryo. So in that context, we have to think about things like ovarian tissue preservation and things, and we will have those conversations, and we refer all our patients to our specialist assisted conception unit to have those conversations. For men, obviously things are a bit easier, but we still recommend that all men have sperm preservation if they want to. Now some people will elect not to have it. It's an interesting conversation because I think a lot of the fear about having families is because of the trajectory of their disease, of their MS. So they're worried that they're going to get more and more disabled, and so they don't want to have a family. But you have to kind of make them think what might be happening 5 years or 10 years from now, when if their MS is suddenly switched off and they're feeling good, you don't want to miss the boat, because they may suddenly have a very different view of the desire to start a family at that point.
Yeah. Okay. Yeah, these questions we asked the HSCT community who'd already had HSCT. What questions do you wish that you'd asked beforehand, or if you're planning on having this done, what questions would you like answered? And one that comes up again and again is what is it actually like going through the chemotherapy? You know, what can I expect from that? It's a really daunting prospect for people.
Yeah, so again, with our protocol, there are toxicities that are predictable. So what I say to my patients is 95% of what's going to happen to you, I will know it's going to happen to you, and I'll roughly know when it's going to happen to you. It's very rare for something to be unexpected and come out of the blue. But the kind of things that we do tell patients about is, at the time we're giving the strong antibody therapy and the chemotherapy, there's a lot of fluid going in, and the drugs that we're giving can also cause fluid retention. And so patients can gain weight really very, very quickly. And we now have changed our protocol. So we're weighing people, you know, sometimes twice a day, just to make sure they're not gaining too much weight, because that has been recognized as a big issue. We also know that the antibody can cause reactions later on. So we have to put them on some steroids for a while to reduce that risk of reaction. And that can also cause fluid retention. Once the immune system is down, then the risk becomes more around infection. And so usually in the second week or so, we're worried that the patient may get a fever and need antibiotics, etc., which is the reason why they're in. Other things that people worry about is hair loss. And yes, hair loss does happen with this regime, but it's temporary. It all recovers. Usually about 3 months after the procedure, hair starts to grow back. People start to notice it all coming back again. Nausea and vomiting can happen, but it's very well controlled nowadays with the medication we have. So most patients don't sort of have that as a major symptom for themselves. You do get deconditioned during this procedure. So one of the things that I'm really stressed with my patients is you're going to feel worse initially. And that's not because your MS has got worse. That's because we are giving you some toxic drugs that would make anybody feel tired and unwell. And particularly then, if you're struggling already to get to the toilet and things like that, that can be even more difficult after HSCT. But this is all temporary and all really over the first few weeks, and then things improve dramatically. Sometimes patients get a real early improvement in their energy levels. They suddenly feel the MS fog that some people describe suddenly lifts very quickly, and they feel so much better. But I always warn people, because they don't think that they're going to go home and they're going to start running around, and you have to sort of say to people, don't do too much until you're 3 months post-transplant. You can do things to keep yourself conditioned and not allow yourself to get too weak, but intensive rehab and intensive exercise, that should only really start 2 or 3 months after the procedure, when you're strong enough to do so.
And what happens when they do go home? What is the procedure then in terms of the follow-up? Are they given any medications to take away with them? What happens if they become ill once they get home and they're not close to you anymore? What advice would you give around that?
So we give all the medication they need. We have regular follow-ups as part of the package. So initially be once a week, and then they'll go to once a fortnight, and then normally by the time they're 2 months out, then they may only need to be seen once more at 3 months. Once I'm happy that the EBV reactivation is no longer a risk, we advise patients, depending on where they live, as to what to do if they become unwell. So if patients live a long way away, we ask them to call us. We'll discuss what needs to be done, but quite often the advice may be you need to go to your local hospital to get seen and get antibiotics or whatever it is that you may need. If they live closer by, we would rather just get them straight up to us, and we will see them.
Yeah, yeah. Well, the next question really doesn't apply to you because it was for patients going overseas asking about the language barrier. So we obviously that's not an issue here. But can you tell us about what the maximum EDSS is that you treat, and whether or not you reevaluate somebody's EDSS? Because we found this, that sometimes when patients have gone to a facility, they've been told that they're one thing, but actually they're told then that there's something else. So how does that work with you?
So we do use the EDSS as a scoring system. It's not the best scoring system. It's a little bit subjective and can also depend on time with the patient. Sometimes patients feel better one day and not so good the next day. But bearing in mind all of that, we wouldn't transplant anybody over 6.5. Just because our data now suggests that once you get 7 and above, you're not likely to get much benefit from the procedure.
And is that the same privately as well as on the NHS?
Yeah,
6.5 max. Yeah.
So we're very clear that we only take private cases if we feel there's going to be a benefit for them. So this decision is not based on whether you've had a DMT or not. This decision is based on whether we think it's going to work for you. And if we don't believe HSCT is going to work for you, we wouldn't offer it to you. And our data would suggest that once it gets above 7, that's the case. Now, the only caveat to that is there's some patients where the EDSS deteriorates very quickly because of the MS. So if you've got this particularly aggressive form of MS where you can go from being relatively okay to being in a wheelchair within a few months, that is potentially reversible. So even though they may be in a wheelchair or even bedbound, because it's happened so acutely, if you get in there with HSCT, you can reverse that disability. So in that context, we would take those kind of cases. They're not very common.
Yeah, it's worth knowing though, definitely. And do you treat any other autoimmune conditions now, or is it just MS?
So MS is by far the most common indication. I actually started doing another condition called CIDP, which is a peripheral neuropathy, not a central nervous system disease. That was my first transplant. I then did Crohn's disease. I've also done scleroderma. Just had patients referred for rheumatoid arthritis as well. So we are doing different ones.
Right.
But in the UK, by far the biggest indication is for MS.
Yeah, but worth those other patients knowing. And is that something that they can get on the NHS as well, or are they private patients?
So again, it's available both on the NHS and privately, but it still has to go through an approval process. So we have to make sure it's the right thing for that patient, close liaison with their referring physician, who's their disease specialist. And if it's felt that that's the right thing to do, then we would certainly consider offering that treatment. There are some trials as well that are opening up. There's a new trial that's opening up for MS patients that will be available on the NHS, the STAR MS trial.
Okay.
And there's also, and that hopefully will open from January, and there's also a Crohn's disease trial as well.
Great. I was wondering, I was going to ask you when the STAR MS one was starting, but you think hopefully January. So that's really good to have that on the horizon. Is that the one which is the multinational trial that's got some in Scotland as well? And
so so across the UK it will be open in different centres. There is at the same time studies happening across Europe and North America, which are similar to our study. So what you hope is in about 5 years from now, we'll have 4 or 5 big randomized trials from different parts of the world that will prove for once and for all HSCT is superior to most of the other currently available therapies.